Hi, Bill Nudera here, and welcome to my channel, dedicated to clinical endodontic education. If this is your first time here, don't forget to hit that subscribe button. If you're already a subscriber, welcome back. The case we're discussing today was an interesting case, and I thought certainly worth sharing. Patient came to me for root canal treatment, tooth number 9, was diagnosed with necrotic pulp and chronic apical abscess. We can see the area of low density wrapping around here to the palatal. As I move this through to the mesial and then back to the distal, it gives us a really good idea of the extent of the damage that we're looking at to the alveolar bone. The clinical exam shows that we're dealing with 2 sinus tracts here and a little bit of redness and some localized swelling. The challenge here is the fact that we're going through a fixed partial denture, a 3-unit bridge. There's a little bit more pressure anytime we're working through restorations that are going to be retained, because there's always the risk that some of the ceramics may fracture, causing an aesthetic issue. Sometimes these restorations don't survive the process, but all that needs to be discussed prior to moving forward with treatment with the patient. We then want to move forward with our aseptic protocol. I chose a single tooth isolation technique using rubber dam blockout material. I was able to make a nice conservative access through that fixed partial denture and was able to find that root canal system pretty readily within the beginning of the treatment. There was nothing really remarkable about this treatment. It was a standard single canal treatment. Things went very smoothly. I was able to fit a cone and went ahead with my obturation technique. This is kind of where things got a little bit interesting for me. At 4 weeks, the clinical exam shows absolutely no resolution to either sinus tract. And it starts making me think about my clinical approach. Did I do something wrong? Did I not do something as thoroughly as I should have? Should I have done this in 2 steps using calcium hydroxide? A lot of things start going through my head whenever I see things that aren't just really moving in the direction that I want them to. Because now we're about 4 weeks out and we're having to consider alternative options. Certainly option 1, I could go back in, retrieve the gutta percha, put some calcium hydroxide in it, and give it a little bit more time to see if it works. It's always a reasonable option. Option 2 would be to consider a surgical intervention and going in there and doing some sort of apical curettage and root end resection. And I believe that surgery was going to be our most definitive option. Although during the consultation phase, I do discuss realistic expectations with my patients and discuss that root canal treatments aren't 100% successful, I certainly wasn't prepared to have a surgical conversation with this patient 4 weeks out of treatment. So this is the day the patient presented for surgery, and as I do for all my surgeries, we want to do a little bit of bone sounding before we actually start making the incisions in the tissue. We want to understand where the bone height is. So the initial probing for this on the facial was about 4 millimeters here. That means if we're doing some sort of submarginal procedure, I need to try to keep this incision within the attached gingiva. That would have put me pretty close to that mucal gingival junction. And I wasn't too comfortable with a submarginal incision here based on that particular probing depth. This is my flap design. I chose to do an intersulcular incision, taking it across the midline, including tooth number 8, taking the papillas with me, and number 10 is a pontic. So I had to design an incision that was going to be as aesthetic as possible, because when I put this tissue back, I want to make sure that I try to make it look as natural as possible. You can see prior to surgery, I'm having my patient bite on a little piece of 4x4 gauze. That way they're not clinching their teeth together, and I think it's more comfortable for them. I'm also packing the vestibules with 2x2 dry gauze to catch any sort of heme that may kind of fall back there during treatment. I swab the area with a little 2% chlorhexidine before I get started to try to keep the field as clean as possible. And I go ahead and I start with my incision. I raise the flap, and we can see why I was getting that 4 millimeter probing depth there on the facial. There's a little bit of a bone loss there. As I'm raising my flap and beginning to curette the lesion, I come across my sealer. So what we're looking at here is a little bit of sealer, and that's consistent with what I saw from the overextension of sealer from my final obturation. Again, I don't think it has anything to do with why this case didn't work, but it is interesting to see. So I was able to remove a significant portion of this lesion from the alveolar bone, and I send all of the tissue that I remove from bone or any surgical procedure for a histological biopsy. I want to know that it is what I think it is, and certainly rule out other possibilities here too. This is what the crypt looks like after most of that lesion is removed. Now, this is a large lesion. We saw from the cone beam scan that this wraps all the way around to the palatal area as well. And we're not really seeing that here in this particular view. We're only seeing the damage to the buccal plate from what that lesion has created. So I've got to make my osteotomy just a little bit bigger in order to remove some more of that tissue in that area. The osteotomy is opened up, and now we see the exposure of the root itself. The root just didn't look right to me. You see the blue areas there. I always throw a little methylene blue on there, some staining agents, to really get an idea of what's going on with the root. I'm looking for fractures. I'm looking for anything here that just doesn't look right. And this root just looked a little bit strange to me. I noticed right there on that distal facial area a little bit of a line. I began thinking fracture. I started thinking, what are we going to do? This tooth is fractured, and it's supporting a 3-unit fixed partial denture. I was ready to throw the towel in on this case and say, you know what? This tooth is fractured. There's nothing we can do. It's got to come out. For sure, that was in the back of my mind, that this may not work because of what I'm seeing right here. We tend to take a little bit more risk sometimes for teeth in the aesthetic zone, for teeth that are supporting long span restorations. And I went ahead and made a clinical decision to further section this root a little bit more coronally, taking off a little bit more root structure than I prefer. But in my opinion, I don't think I had much of a choice. Before I made that section, I wanted to make sure that there was enough bone remaining. If that bone is damaged and we now develop some sort of facial probing, the prognosis for this tooth decreases even more than it already is. So I do have a nice, healthy collar of bone there, and I'm going to try to maintain that. So I made a second section of this root a few millimeters above my first section, taking off about 5 to 6 millimeters of this root, but I was trying to resect the root a little bit coronal to where I saw that defect. And again, I'm not 100% certain it was a fracture. I'm not 100% certain it wasn't. It could have been a cemental tear. It could have been just been an external root defect of some kind. But either way, I had to bring the root coronal to the level of that defect in order for me to feel comfortable about moving forward. This is the piece of root that I was able to remove. Couple things I want to point out. Look at that obturation. Not bad for a single cone obturation. We can see nice sealer distribution. We can see the gut aperture right in the center. This is what we've got left. A much larger osteotomy than what I was planning. But there's a benefit to this. The benefit was that I was able to get a curette and get around to the palatal area and get some of that tissue that was over in that palatal region. So I was able to clean the lesion out a little bit better because I had better access. Now again, I'm kind of trading one evil for another, but if there's any silver lining to this, I was able to access that palatal tissue a little bit better. I threw stain on there one more time just to make sure there were no fractures, and I was able to look at the apical portion of the sectioned root, and I felt comfortable with what I was able to establish at this point. Using ultrasonics for the root end preparation, everything was completed without any issues. And what I do before I place any sort of root end restoration is I'll try to dry it. Excess moisture can affect the setting time of these bioceramic materials. So I'll typically bend a paper point and I'll place that paper point inside that root canal system after it's been prepared just to wick up any sort of moisture prior to the placement of my bioceramic material. The root end filling was placed with a bioceramic putty. For me, the putty is a little bit easier to handle and easier to manage. I placed and condensed the bioceramic putty about 3 millimeters into that root end preparation. So after a good thorough irrigation, then we make the decision whether or not we want to do any sort of bone grafting. I typically will like to graft all of my crypts. I know there's some controversy around whether we should or shouldn't. I know the literature says we don't have to, but for me, again, it's something that makes me feel more comfortable. So I'm using a DFDBA grafting material, and I'll typically just fill the entire graft. You don't want to overfill it. There's no benefit to overfilling these grafts. I try to make the graft flush with the buccal cortical plate. Then I protect it with a membrane. The membrane is then trimmed to fit the size of the osteotomy that was created, and it's placed right over the crypt and the graft material. I over-trimmed this membrane, and we can see there in the apical area there's a little bit of exposed crypt there. I could start over, I can open up a new membrane, and I can retrim, or I can take a piece of the membrane I have, and I can overlay it, I can stack it. There's nothing wrong with doubling up your membrane in that area. I merely just placed another portion of that same membrane over the existing membrane to cover the defect in its entirety. Zooming out just a little bit, you see the entire surgical field with the membrane in place. Suturing is so important when we talk about surgery. Repositioning that tissue in the exact way that you want it so that you get the healing that you expect. So it's like putting a puzzle together. So I'll typically throw one interrupted suture in right at that corner of where I made that releasing incision. This will essentially hold the tissue in place while I work on reapproximating that tissue. The second suture I put in is a sling. I sling that tissue around tooth number 9 in order to pull it coronally. Once the tissue is in place, I move forward and I suture the releasing incision, starting apically and moving coronally. This is what the final surgical field looks like after the sutures have been completely placed. So this is the final PA. Happy with it. Again, I took a little bit more apical root structure than I was planning to, but overall, I think the case looks good for what I was dealing with. And now it becomes a waiting game. We've got to see how this area is going to heal. So I get the biopsy report back for this case, and it comes back as a cyst. There's always a little bit of satisfaction for me whenever I get a biopsy report that says that we're dealing with an apical cyst, because I know that no matter what I would have done internally for this root canal system, it never would have solved the problem externally. So moving in the direction of the surgical approach was in fact the right move. So this is what the surgical site looks like at 10 days. So the sutures are removed, and I look at this surgical site. Now remember, we're only 10 days out. So I think from a healing standpoint, with the way the tissue looks, there's a lot of benefits here from what we were able to do with the surgery. But I do see some concerns 10 days out. Number one, I see a little white spot that is developing kind of in that apical area there. And what that is at this point in time, I'm not ready to make a judgment call on that, but I'm concerned about that. So I'm going to have to keep my eye on that. The second thing I really don't care for, what I'm seeing here, is the recession now that I'm dealing with around tooth number 9. This is not the outcome I was hoping for in this particular situation. I look at this initial outcome, and it goes back to my suturing. If I look at my final suture placement, we can see that the tissue was not approximated as far coronally as I needed to. I thought it was, but it wasn't. And now I'm left with this defect. At the time of the placement of this flap, I didn't want to put too much tension on the flap, so I chose to position it where it was going to fit passively. In hindsight, I could have released the periosteum. I could have done something differently in order to approximate this tissue a little bit further coronally, but I didn't. And now this is what I have left to work with. So we're going to see what happens over these next few months, see if it's going to improve, see if I need to do anything else to augment it. If I have to, we'll consider doing a coronally repositioned flap. There's some options, but I'm going to reserve those options and those discussions for at least a good few months down the road. So stay tuned. I hope you've enjoyed this video presentation of mine today, and I look forward to seeing you on future videos. Remember, don't forget to hit that subscribe button. I'm Bill Nudera. Thanks for watching.